I'm just starting to my conference about the new recommendations for the diagnosis of prosthetic joint infections and some news about the new unified definition that are under way, hoping that we have it published in a few weeks. This is my conflict of interest. And we will start with a clinical case. This is a case of a 78-year-old man who underwent a hip arthroplasty, and 6 days after surgery, the patient started with the symptoms of what we think it's an infection, a prosthetic joint infection. Their procedure was performed, and samples were submitted to the microbiology department for performing the etiological diagnosis. And in the samples are Klebsiella pneumonia producing carbapenemase, KPC carbapenemase grow in all the samples, and then the treatment started with ceftazidime-avibactam. The patient worsened, and a two-stage exchange was then performed. And despite prosthesis removal and antibiotic treatment, the infection was progressive, and 15 days after the starting of the treatment, the patient developed sepsis caused by the same organism, and even when amputation was performed, the patient died because of septic shock. This case explains that the problems that can appear with the diagnosis of prosthetic joint infection, which is a very important problem in these days, as we can see in the next slides. Prosthetic joint infection is an important cause of failure of arthroplasty throughout the world, and they has a great impact in morbidity, mortality, and increases costs of this procedure. It is a problem that has been known in the first year of the introduction of joint prosthesis in orthopedics. Here we have an article of Professor Charnley when it appears the first cases of prosthetic joint infections following the arthroplastic procedure. Despite its importance, prosthetic joint infections are a relatively uncommon complication of arthroplastic surgery. It appears in a variable percentage of cases depending on the institution, but in general, we can have 0.5 to 2% of our knee prosthesis incidence, a lower incidence for hip prosthesis, and less than 1% for shoulder prosthesis. Data from other prostheses are lacking in the literature, probably because the low number of cases. During the last years, there are data that suggest that the incidence could be declining, probably because the improvement of preventive measures. However, because the number of patients with uh, the use of this prosthesis, that the number of patients with arthroplasties are increasing, it is expected that 1 million patients have total hip arthroplasty and total knee arthroplasty this year in the United States, and it is predicted that 2 million will be performed just in 4 years, and probably in the European Union, the number is more or less could be more or less similar. Well, there are no register for all the European Union, so probably the total number of patients with this prosthesis will increase during the next years. Here is a publication with the expectance of the use of prosthesis. We can see the number of prostheses in the United States to be used is increasing, and this means that with an incidence of 1%, average incidence for all prosthetic joint infection, this means that 20,000 patients will have prosthetic joint infections in 2030. But probably it can be higher because these patients can have also increasing number of comorbidities, increasing fragility, so probably the incidence could be even higher. One of the important problems that we have with prosthetic joint infections is about etiology, because almost all microorganisms can cause prosthetic joint infections. It is well known that prosthetic joint infections are usually monomicrobial, and the species that can cause the infections, while almost all microorganisms can be the cause, there are some microorganisms that are more frequent than others. In all cases, Staphylococcus is the most frequently isolated genus among all different kind of infections. uh, gram-positive species represent about 70 to 80% of all species, following by gram-negative species, then anaerobes and other microorganisms that are extremely uncommon, and fungi, mycobacteria, and other isolates are exceptional. We expect also a variable percentage of polymicrobial infections, which is between 15-20% in most serious, and we have even a variable percentage of negative cultures, despite all the efforts to perform the diagnosis of prosthetic joint infection. There are also differences according to the characteristics of infection. And these differences are very important in order to establish the management of the patient, especially the empirical treatment of these prostheses. In this work by the Spanish group of osteoarticular infections, we can see the differences between early prosthetic joint infections, acute prosthetic joint infections, chronic, and postoperative, positive intraoperative cultures between the different species. In the next slide, we can see a graphic with the more easy to read data about the different numbers. As you can see, the Staph aureus represented the most important species in acute infections, both in early postoperative and acute hematogenous infections. But coagulous negative staphylococci, mainly Staph epidermidis, appear as the most important microorganism in late chronic and positive intraoperative cultures. Other microorganisms appear in lower amounts, except for enterobacteria for early postoperative infections and acute hematogenic infection. We can see the differences among post-surgical infections depending on the time or after the surgery. In the same paper, we can see the differences between the different times for surgery. Here we can see the different etiologies in less than 1 month since surgery. Staph aureus and enterobacterales appear as the most important microorganisms, and after the first 2 months, it seems like that coagulous negative staphylococci appear as the most important microorganisms. As you can see in this slide and in the past slides, fungi and other microorganisms are very uncommon. This etiology is obtained by microbiological assays because microbiology plays a very important role in the management of these patients because it performs the etiological diagnosis of bone and joint infections, including prosthetic joint infections. However, microbiology does not make the diagnosis of a bone and joint infection or prosthetic joint infection. This process includes also clinical data, imaging, and other laboratory tests, and a patient can have a prosthetic joint infection even with negative microbiology. In this review that we have published last year, we review the different aspects of the culture of different samples for the diagnosis of prosthetic joint infections. And in the next slides, we will see the differences between them for performing this diagnosis. The first sample that we are talking about is synovial fluid. This is one of the classic samples. It's very useful for acute infection, less useful for chronic cases, probably because in the chronic cases the importance of biofilm is higher than in acute infections. We know that sensitivity increases if the synovial fluid is inoculated in blood cultures. And most important, this sample can be used preoperatively. It is very important because in some cases it can be obtained easily, but some other cases is less useful because some cases it can be hard to obtain the sample, especially in chronic infection. Dry taps can be can appear, especially in chronic infections. But this is a very important sample, and some probably can be used in all cases if possible. Gram stain of synovial fluid has a very low sensitivity. It is about 25-30% in better in the best cases, but probably is lower in clinical routine. And there are publications where gram stain in clinical routine has a sensitivity of about 15%, which is very, very low. In some cases can be useful, but probably in most cases there are other tests that have a very better performance than gram stain. Here are the recommendations from our review. This review has been published, as we will see, as part of the Unified Definition task force and published separately as other publications. And as best practice in our review, we have seen the inoculation in blood cultures, the need to a prolonged incubation if necessary, especially for anaerobic cultures, which need to be maintained after 14 days if a clinical suspicion of infection exists, and the interpretation of the results is sometimes very difficult. If virulent microorganisms grows, it is more probably that this microorganism can be the cause of the infection. However, if the microorganism detected in synovial fluid is a common contaminant or a pathogen of less pathogenic potential, like Coagulus negativus staphylococcus or Corynebacterium or Cutibacterium agnes, it must be looked with careful. It must be carefully interpreted because it can be a contamination and not a true isolate or a true cause of the infection. A negative culture does not exclude prosthetic joint infection. This is also very important. And the most important recommendation in this part and in the next one is do not use swabs. Swabs are not recommended in the diagnosis of prosthetic joint infection in any case. It is preferable to send the sample as is to the microbiology lab and then to perform proper cultures if necessary. For pre-prosthetic tissue cultures, we have it is the conventional, is the classical method that is the current gold standard for diagnosis of infection, and interpretation of the results has been performed usually with the Atkins criteria, although in many cases modified. Sensitivity can increase if liquid media are used, especially blood cultures. In our review, we have seen the blood cultures increase sensitivity more than the conventional liquid cultures in tubes. It is necessary to use a long incubation time in order to detect slowly growing microorganisms, and these samples can detect the presence not only of planktonic bacteria but also intercellular bacteria and probably biofilm-related bacteria. We can see in the next slide the recommendations are more or less the same that for synovial fluid. The number of samples to be submitted to the laboratory must be between 3 and 4, depending on if blood cultures are used or if blood cultures cannot be used in the lab. The detection of two identical microorganisms in two different specimens is diagnosis of prosthetic joint infection. If one only microorganism in one sample only is positive, if the microorganism is a true pathogen like Staph aureus or Pseudomonas aeruginosa, probably it is the cause of the infection, but it cannot be considered a definite diagnosis of infection, as we can see in the next slides. However, even the detection of these microorganisms must be considered as a potential contaminant if the patient has no other symptom or symptom of infection or no other test that suggest to perform an interpretation. Again, negative cultures does not exclude prosthetic joint infections, and swabs must not be used for the cultures of periprosthetic tissues. And then we have sonication. Implant sonication, the sonication is not reviewed in the previous work, but it is a very useful tool in the clinical microbiology lab. Sonication uses ultrasounds to detach bacteria from the biofilm from the surface of the implant using a mechanical methodology. This method started to be used almost 20 years ago. The seminal publication of Andrew Campos and the Mayo Clinic team about the use of sonication in 2007 was the starting point for the use of this methodology in all laboratories. However, not all laboratories implemented this use. In a study performed in 2022, in Europe, we have seen that roughly between 50 and 60% of the laboratories use sonication, and the other 50 laboratories does not use sonication. The use of sonication has been reviewed in many cases, and I think, and our team thinks that it is a very useful methodology because in any other case, the implant cannot be cultured. And this is very important because implant is very important sample, especially in chronic infections where biofilm can be detected in the surface of the sample. In this meta-analysis from Watanabe and collaborators in 2024, we can see the differences in sensitivity between the different samples, and sonication has the higher sensitivity among all the potential samples to be used. However, this meta-analysis analyze mainly studies that are performed uh, under experimental conditions or series of that studies only sensitivity and specificity. But what is the impact of the sonication for the diagnosis of prosthetic joint infection? In our team performed a study in 2018 about the usefulness of sonication in the diagnosis of prosthetic joint infection, and we conclude that about 16% of the patients were diagnosed only when sonication was performed. If we are not, if we was, if sonication was not used in our study, 16 patients cannot be diagnosed. These results have been confirmed last year when the team of Yusuf and collaborators published this study in the Clinical Infectious Disease. And as you can see in the slides, there are about 15% of the cases sonication has an impact in the management of the patients, which is a result that is quite similar to our previous published experience. Probably, and the authors established this issue, the main problem of sonication is the lack of a standardized methodology for performing this technique. There are many different protocols and criteria for sonication, some quantification performing to have a breakpoint or to have not a breakpoint. It depends on the protocol that is used. So sometimes it's very difficult to establish uh, a common protocol of sanitation because all hospitals have their own established sanitation methodology. This is a problem to compare the results between one and other center. However, yes, we have seen probably the culture-based diagnosis seems to have reached its peak. We have prolonged incubation, we have sanication, we have the protocols for synovial fluid or preprosthetic tissues. However, despite despite the improvement of during the last year, there are patients with negative culture results. Uh, the reasons are very different, and it is included in this slide. But for these and other patients, probably we can use another methodology, which is molecular biology. This could be a very useful methodology that has been performed and tested many years ago. It has been used for prosthetic joint infection. We have three different types of technique: the homemade PCR, the commercial multiplex PCR, and the next generation sequencing. And probably this methodology will have a very important place in the next future. A recent review, as you can see in the slide, show the usefulness of this technique, and they have been included in the high definition. And here we started about the usefulness of definition. Here we have seen a historical guideline of the differences between the different definitions of prosthetic joint infections that has been used during the last years. The last definition was that of the EPGs, but there are other definitions that can be used from the different societies. So we have different prosthetic joint infection definitions between the different societies, more or less similar, but with some differences. The advantage is to have the prosthetic joint definition is the more sensitive criteria, the ability to perform clinical validation studies, but we have also disadvantages. Different reference standard, which complicates highly the comparison between the studies. And a very important issue is the confusion amongst physicians. Which criteria we must use? We must use the EPSI criteria, we must use the MSIS criteria, we must use the ITSA criteria. This is a problem sometimes in the current clinical practice. So for these issues, different societies involved in the management of prosthetic joint infection joined in November 2023 to establish a unified definition that can be applied for all the societies, the international societies involved in prosthetic joint infection management. We established that no financial conflict was allowed. We established that none of the societies can claim the credits for definition, and we established different groups, different working groups for the evaluation of the different methodologies to perform the diagnosis of prosthetic joint infection and perform systematic review and meta-analysis using common search, literature search, and grading of evidence. Next. And here are the definitions that we have finally decided. The standalone criteria means that one of these criteria is diagnosis. There is diagnosis of prosthetic joint infection. There are clinical features that sinus tract communicating to the joint. There are microbiological criteria, two positive cultures, and one positive culture from synovial fluid or sonicate, plus one positive culture from periprosthetic tissue, which means that you can have one positive culture from synovial fluid, for example, and one positive culture for periprosthetic tissue, and this is diagnosis. And we have the histology as a criteria to perform the diagnosis of prosthetic joint infection. This standalone criteria has been demonstrated that has more than 95% of sensitivity to perform the diagnosis. And we have also supportive criteria, which means that one supportive microbiology criterion plus one of other criteria is also diagnosis of infection. We have microbiological criteria, imaging criteria, and inflammatory markers criteria. The use of one microbiological criteria plus one of the other criteria is supportive of the diagnosis of prosthetic joint infection. The team also established flow charts for the diagnosis of different prosthetic joint infections. This is the diagnosis of early postoperative infection. This is more complex for the diagnosis of late postoperative infection. And we have one last flow chart for the late acute infection, the hematogenous infection. All this unified definition has been endorsed by the executive committees of the societies, the ITSA, the EPGs, the MCs, the ESCMID, and the ICM. And a manuscript was written, and we hope that this manuscript will be published soon. And then, after publication of this unified prosthetic joint infection definition, we will have the intention to perform clinical validation studies. So to take home messages, we can see in this slide the main message that we must have is that the management of the prosthetic infection is a very complex issue that includes a multidisciplinary teams between infectious diseases, trauma, microbiology, preventive medicine, infirmary, and research, and all together are dedicated to perform not only the diagnosis of prosthetic joint infection, but also the management of the patient. Thank you very much for your attention and looking for your questions.
So thank you, Jamie. That was a great presentation. I'm Pier Indelli. I'm an orthopedic surgeon in Italy, in Trentino, in the Trentino Alto Adige region. So these are my conflict of interest. So as Jamie say, periprosthetic joint infection is a devastating complication, and this is for patients and also for the healthcare system. So if you look at mortality and we compare septic revisions with aseptic revisions, you see that the mortality in aseptic revision at 1 year is 5 times uh, higher than aseptic. At 2 years is 3 times higher than aseptic, and on 5 years is almost double. So this is a major problem for patients. So also from a socioeconomical point of view, this is a Markov analysis from the United States. We know that in the United States, the cost of the healthcare is higher than other parts of the world. But if you can see here that the average cost for a periprosthetic joint infection for a patient 55 years old is almost $500,000. So as Jamie just showed, there are profound differences. I call it transatlantic differences between Europe and North and Central America and South America and the rest of the world in PJI diagnosis and treatment in 2026. And as Jamie just showed, we all start, using in the 2018 this unified criteria definition by the International Consensus Meeting. And they were identified the major criteria, and the two major criteria were two positive cultures of the same organism of the presence of the sinus tract. And you see the probability of PGI was evaluated independently at each step. Step one, the serological markers. Step two, synovial markers. And step three, intraoperative histology. So in 2023, as Jamie showed, a group of scientists and infectious disease specialists and microbiologists from the European Bone and Joint Infection Society try to highlight the differences between the different scientific societies all around the world. And even in this publication, you see that in 2023, we were still counting on standard microbiology for microorganism identification. But we know, and we know now in 2026, but this is a concept that we know for many years, the sensitivity, especially the sensitivity of the synovial fluid culture is very low. And culture negativity PGI reach a 35% rate even in top PGI dedicated institution like the Rodman's Institute in Philadelphia. And you can see here that the treatment failure rate is up to 73%. So we think that in 2026, PJIs are underdiagnosed and probably multibacterial. Early identification of the causative organism is one of the main determinants for success. And molecular testing technologies like the multiplex PCR, the JI panel by Biomiru, and NGS, next generation sequencing technique, represent really a game changer in PGI diagnosis and treatment because they can lead to a tailored medical and surgical treatment. So in 2026, as Dr. Esteban just showed, we have three major options. You know, I don't talk about the homemade PCR technique, but this is something that is commercially available to everyone worldwide. There is the syndromic, the multiplex PCR JI panel. It's a panel with up to 39 microorganisms. Very important information here. The turnaround time is about 1 hour. Then we have the 16S targeted next generation sequencing. There is an amplification of the 16S gene, and the turnaround time is a little bit less than 72 hours. And then there is this new technology, the metagenomic next generation sequencing, where the whole genome is sequenced and it's compared against a database. The turnaround time is between 3 and 5 days. So this is the BioFire joint infection panel, the JA panel by BioMeru. Is a multiplex PCR. They have 39 targets, and the turnaround time, as I told you, is a little bit less than 1 hour. There are some pros and cons of this technology. So, for example, there is no Staphylococcus epidermidis, there is no C. acnes, and this is due to maintain high sensitivity and specificity, but we can identify microbiological resistant genes and MRSA. Next slide. And in our hands, and in my hands in particular, this is the ideal molecular diagnostic test for acute periprosthetic joint infections. And so I had the honor to work as a team leader and also expert at the International Consensus Meeting in Istanbul in the May 8 to 10, 2025. And we try to review the literature. And first of all, we try to understand the definition of an acute periprosthetic joint infection. Because in an acute setting, in an acute scenario, me, like many others orthopedic surgeons, can we try to save the implant? So the recommendation from the consensus meeting for there in 2026 these are the following. Infection within 6 weeks of the index arthroplasty, onset of symptoms of less than 7 days, and a well-fixed and stable implant. And you see an agreement between the delegates about 77%. So in 2023, we published this PJI diagnostic algorithm in every single case where we suspect an acute infection. We change a little bit the surgical technique from Bayer to DAPRI because we strongly believe in local delivery of antibiotics using antibiotic headed calcium sulfate beads. And this is the algorithm that we use in our emergency department. First step, serological markers. Second step, synovial markers. And if these are elevated, we move towards molecular diagnostic. We started with the multiplex PCR and culture. And if the JI panel is negative and the culture is negative, we move to next generation sequencing, and we expect probably a low virulence PJI and maybe even polymicrobial. So this is the evaluation form. It's a scoring system that we use in our emergency department when we have a suspect of a septic arthritis or a PJI. You can run basic serological and synovial screening in less than 3 hours. And then if you have a score more than 6, you move to molecular testing and the joint infection panel, and the turnaround time, as I told you, will be around an hour. So this is one of my patients, 70 years old male. This patient came to the emergency room. In Italy, is pronto soccorso, so you see PS. Look at the timing, 10:30 a.m. Patient had fever, knee swelling, redness. At noon, we had the result of our serological and synovial test in terms of PCR, sev rate, and synovial WBC, PMN's percentage, and also the synovial PCR. The score was 9, so this patient was infected. We send the sample for multiplex PCR. So the syndromic panel came back in 1 hour, and we identified the Staphylococcus aureus. In this case, was a MSSA. So at 2 p.m., our anesthesiologist started targeted antibiotic for these patients, and the patient at 4:30 p.m. Underwent arthroscopic irrigation and debridement of this knee. So as I told you, we use these DAPRI procedures instead of a classical there. This is again one of my patients, 73 years old female, fever, knee swelling, skin redness. She had a primary total knee done 20 days earlier. The patient went to the primary care physician, was put on oral antibiotics. The laboratory testing you see there elevated PCR, elevated surge rate. Unfortunately, because of the patient was on antibiotics, the culture was negative, but the synovial markers were all elevated. So this patient underwent DEPRI, so surgical debridement, and this was guided by molecular diagnostic. During the real open exploration, we perform the intraoperatively, and this is a huge advantage of having a molecular testing technique available intraoperatively. So we identify intraoperatively the microorganism, was a MSSA. We perform a tumor-like debridement guided by the methylene blue as a intraarticular disclosing agent. We use the argon beam on the metallic component. We perform acetic acid lavage, a chlorhexidine scrub, a povidone iodine wash, and finally an irrigation with 9 liters of high volume worm saline. The polyethylene insert was exchanged. We place intraarticularly the calcium sulfate antibiotic-added beads, and we put a drain for 48 to 72 hours. And you can use the same approach for culture negative PJI. Dr. Esteban just showed the growing incidence of culture negative PJI. Sometimes we use this surgical approach, which is called the 1.5 stage revision. So this was a culture negative PGI. We were able, thanks to the JI panel, to identify intraoperatively the microorganism was a streptococcus. In this case, we decided to use a dynamic spacer made by a PS femur and a old poly tibia, and we built our custom-made antibiotic-added beads thanks to the identification of the microorganism. You see some of the surgical step with the removal of the implant. And then you see the patients after 2 days, after the positioning of this one stage spacer, was sitting comfortable in his wheelchair. You can use molecular diagnostic also in 2-stage revision. This is one of the patients that came to our hospital, 69 years old, male, fever, knee swelling. He had a revision totally done 1 year old, and he had a sinus tract, right? So he had a major criteria. So we knew that this knee was infected. The patient was on oral antibiotics given by the primary care physician. We ran the serological synovial testing. All those markers were elevated. Again, the culture was negative, and the knee was infected. Intraoperatively, we identified 2 microorganisms in this case. So this was a polymicrobial PJI. You see the Enterococcus and the Staph aureus, which was likely a MSSA. And so the patient underwent 2-stage revision for a polymicrobial intraoperatively diagnosed PGI. And the first stage of the 2-stage, we put a dynamic spacer. We built again our custom-made stimulant beads, and we use an Hemovac drainage for 72 hours. So you can use the molecular diagnostic also to rule out chronic PGI. This is a 89 years old male. He had a failed endomodel, so this is really a orthopedic arthroplasty disaster. Looking at the X-ray, he might have had periprosthetic fracture, the medial femoral condyle. He had a major effusion. The serologic markers were elevated. It was culture negative. So we perform intraoperatively, sorry, because the report is in Italian. We ran the biofire intraoperative. There was no microorganism there. So the patient underwent one-stage revision for aseptic loosening. And you can see the X-rays, intraoperative images, and post-operative X-ray. And this is another case. This is an interesting case. It's a one-stage revision in a 66-year-old patient. We identified a streptococcus preoperatively. We confirm it intraoperatively using the JI panel. Next. As you can see here, sorry, slow motion, we like to use 2% chlorhexidine lavage. Next slide. And then we like to brush the joint. And before placing the new implant in, we like to place intraarticularly and intracanalically antibiotic added beads. And this is the post-operative X-ray of this patient. You see the implants there with the antibiotic added beads. So we look at our database. So we start using, as I told you, this diagnostic algorithm in 2023. We look at our first 43 septic arthritis and periprosthetic joint infection cases. You see here that in 26 PJIs, molecular diagnostic was determined to identify the microorganism. You see 65% of the PGIs, molecular diagnostics, help us to identify the microorganism. This also, if you move to the native septic treated cases, you see even more. In 88% of the cases was the determinant for microorganism identification. So we got very excited about all this data. So we built a study group, multi-institutional study group under the umbrella of ESCA and ECA, and we perform a scopy review and to propose a more detailed diagnostic flow chart. We review systematic reviews, meta-analysis, general reviews, published on molecular diagnostic PGI, and we try to propose a molecular diagnostic-based flowchart for periprosthetic joint infection. So we identified 75 articles, and we found that the sensitivity and specificity of multiplex PCR and NGS were very, very high in the 90s and 100. So the take-home message of this scopy review was that, yes, as Dr. Esteban Moreno just said, culture is in 2026 still the gold standard, but we can get a lot of help in identifying the microorganism from molecular diagnostic. And what we highlight is that acute and chronic PJIs have different diagnostic pathways because they have different responsible microorganisms. All this work was brought to the international consensus meeting, and I had the honor to work in this study group. And our question was, is there a role for the use of molecular techniques in isolation of infecting microorganisms causing periprosthetic joint infections? So we went back to the database analysis. We retrieved 642 articles, screened 267, and the final number of publications analyzed were 50. So again, we scrutinized essentially PCR techniques and next generation sequencing techniques. And so we highlight this possible utilization of molecular techniques. Culture negative PGI, like Dr. Esteban say, in a preoperative testing scenarios, especially when patients are on oral antibiotics, when we have a polymicrobial, we suspect a polymicrobial PGI or a PGI caused by a rare pathogen, or when the speed of the result, the turnaround time, is very important to guide our surgical treatment. So to answer the question, is there a role for the use of molecular techniques in isolating infecting microorganisms causing PJI? The answer is yes. Molecular techniques are promising adjuncts to conventional methods for diagnosing PGI and isolating the microorganism. These techniques are very beneficial in culture negative cases when rapid pathogen identification is critical and when rare pathogens are suspected. And when we were down to voting, we had almost unanimity. 92% of delegates approved this recommendation. And this recommendation has been recently published in Journal of Arthroplasty, so I recommend you to download this article. And the diagnostic algorithm on the right side, you can see that there are different pathways for acute and chronic periprosthetic joint infections. So Jamie just talked about this one, the new unified criteria for periprosthetic joint infection diagnosis, approved by the European Bone and Joint Infection Society, International Consensus Meeting, Musculoskeletal Infection Society, Infectious Disease Society of America. And you can see here the molecular diagnostic was recommended because of a specificity of more than 80%. So in conclusion, in 2026, microorganism identification represents the critical factor in my hands in the fight against septic arthritis and periprosthetic joint infections. Uh, Several molecular diagnostic techniques are available. They have high sensitivity and specificity, and I think they are rapidly changing the clinical and surgical approaches to the treatment of musculoskeletal infections in general and PGIs in particular. Thank you so much for your attention. And this is my email address, and I'm here. I'm happy to take any questions from your side. Thank you so much.
All right, both, thank you so much. That was very informative and a lot that we were able to learn as we were working through that. So thank you again for the detailed presentation, and I hope everyone in our audience enjoyed it as well. We will begin the Q&A portion of our webinar. As a reminder to everyone still here in the audience, you can continue sending in your questions using the questions panel. We have already received a couple, so we will go ahead and actually start with those that we have here. And I will leave these open ended and allow you, our two panelists to kind of answer them accordingly. So, the first one that we have is if there is a collection very near to knee prosthesis but not communicated with prosthesis, is imaging enough to rule out PJI?
I'll take that one, Jamie. Uh, Unfortunately, imaging helps a little bit. It's been by Dr. Esteban and some colleagues. It's been included in the new unified criteria as a minor criteria. The specificity is a little bit more than 80%, but uh, if I can pull myself away from those criteria and I think as more an orthopedic surgeon, they are not very helpful in detecting what is intraarticular and what is extraarticularly. We are talking about cellulitis versus deep infection. So in my experience, it's not a standalone criteria and it doesn't help me that much. At that point, I still need to stick a needle in the joint and see if I have fluid and I want to analyze the fluid with, synovial, look for the synovial markers, look also for culture because it's still the gold standard and eventually molecular diagnostic. I don't know if Jamie has a different approach to imaging.
No, I think it's the same idea, especially if because to rule out an infection, you need a technique in general in all the infections. You need a technique that has a, sensitivity about 100% because you need to remove all the potential cases of prosthetic joint infection, even if you have a specificity lower than 90%, for example. You can have false positives, but you cannot, you must not have false negatives to rule out an infection. So most of these methodologies, cultures, PCR, imaging, and so on, are techniques devoted to perform the diagnosis. It's a positive diagnosis. So if you have a negative result, you cannot rule out. You cannot rule out an infection with a negative culture. We cannot, you cannot rule out an infection with molecular biology. You cannot rule out an infection with imaging and so on, because these techniques has a sensitivity lower than 95% in many cases. So the need of a rule out methodology, it is clear, but we have not such technique in the present moment.
Perfect. Thank you so much. And then, Dr. Indelli, I think you had another question that you wanted to get us started with as part of this portion as well for Dr. Esteban.
Jimmy, you want to ask me something from the microbiologist to the carpenter? And I'm
Yeah,
the carpenter.
yeah. From the lab to the clinical. It is a question that is open because these new molecular biology kits that has very results faster. So the question is, what do you need? Uh, what time is the maximum one to have a technique that can be used intraoperatively? Because the main problem is to have a patient. I suppose that the main problem is to have a patient open during more than 1 2 hours. It is a risk of infection in this case, in fact. So, what is the maximum time that you need for to perform this methodology?
Yeah, that's a very good point. The 1 hour is probably the best time because we have to decide intraoperatively, for example, if to perform a one stage, 1.5, two stages. And, if we identify the microorganism, many of us push towards one stage because it's a better procedure for the patient. It's a better procedure for the surgeon. It's the better procedure for the healthcare system because it's less expensive. So the point is that we don't have a single test, but around 1 hour will be great, and that's the reason that we use when we have an acute infection. And I show you a few of my cases, both on septic arthritis and there DAPRI. When we in the time that we open the joint, we get the fluid out, we send it for molecular
Mhm.
diagnosis, we start cleaning the joint anyway. We do synovectomy, we remove the mobile components. At that time, we're waiting for the result and see if we have the microorganism. So, for example, I can do DAPRI and identify the optimal antibiotic for this patient. Or if I identify the microorganism, maybe I do one stage. Having said that, at the consensus meeting in Istanbul, we agree that microorganism identification is not anymore an absolute criteria for one stage versus two stage. So we can perform one stage. There is not a contraindication not identify the microorganism anymore. So this has changed a little bit, and maybe will allow us to do more one stage. But again, 1 hour.
Okay.
And Alisa, can I ask a question to Dr. Esteban too, since we
By
are
all
in this?
means.
Thank you, thank you. So, I'm very excited about this new unified
Mm.
criterias, but I'm a carpenter, I'm an orthopedic surgeon, and I have a lot of lawyers in my back
Yeah.
because they look at what I do and if I do things correctly or not. So, do you see any potential problems in the introduction of the new unified criteria really in the clinical practice, in the day-by-day practice, in clinic as well as in the OR?
I think no, because in most cases the unified definition is more or less there is no revolution. There is no revolution in the criteria. As you can see, the criteria, the standalone criteria, are the current standalone criteria in most cases, which is a positive microbiology in two or more surgical samples, plus the appearance of drainage from the wound or similar or clear clinical symptoms from infections. So in fact, we have no revolutionary criteria. We have included some criteria that has not appeared even in the definition, like the use of In the disease definition, there are two samples of periprosthetic joint infection or periprosthetic tissue or sonication higher than 50 colonies. We have mixed this microbiological criteria into one criteria, which is to surgically obtain samples positive, which means synovial fluid, which means sonication of the implant, which means prosthetic tissue biopsies. And we have included also the molecular biology, which is, I think it's very important because molecular biology has not been included in in most definitions, because it is more or less experimental. There are until these last years, there are no clinic and no commercial methods to perform this diagnosis, and now we have the, the multiplex PCR that allow us to perform the diagnosis in a short period of time with high specificity and sensitivity for the microorganisms included in the kit. So this is very important because the inclusion of molecular biology and the the mixing of some microbiological criteria are more or less the only new criteria in most cases. All the other criteria has been very commonly used in previous criteria, but probably the most important impact is that all the societies have the same definition, which means that all of us perform the diagnosis of infection using the same criteria. And this is very important to compare
Yeah,
studies.
I see a little problem there because molecular testing technology is not available worldwide
Yeah,
yet. Maybe soon, maybe soon,
yeah, we
and
hope.
that's yeah. We hope it will be available for everyone because we don't want to have different approaches and protocols in different countries. But hopefully we'll have it available soon on a
Yeah,
worldwide scale. Yeah.
yeah, but in fact, these criteria are not mandatory. Yeah, except there are some recommendations, even in the flow charts, and these are recommendations you can perform. Or if you don't have sonication, for example, I told you that about 50% of labs have no sonication technology for the diagnosis. So you can perform the diagnosis of prosthetic joint infection even without sonication or even without molecular biology. But if you have sonication or you have molecular biology, then you can use the unified definition criteria.
Right. Then the next question that we had is for acute PJI, the 2025 ICM recommendation include the multiplex PCR as part of the diagnosis. Why in the unified criteria molecular methods is not mentioned in the microbiological standalone criteria as an adjunct to culture? Is there a specific reason?
Yeah, the fact is that specificity is not higher than 95%. We established 95% as the breakpoint to define a criteria as a standalone criteria or a secondary criteria, and in the systematic review performed by the molecular biology team, the sensitivity, the specificity of molecular biology is below 95%. It's 94%, in fact, 94, 93%, but it is behind 95%. So it cannot be a standalone criteria. Probably in the next future, if next generation sequencing evolve like all we hope that it evolves, uh, with higher sensitivity, with higher specificity, with better established criteria, probably in the next future, molecular biology can move from supportive criteria to standalone criteria. But with the breakpoint that we have used, it was not possible.
Perfect. And then we have one final question before we'll wrap up for time today. Is there a specific reason for not recommending 16S as a second intention along with NGS for acute PJI?
So it's not available in many hospitals, center or institutions, right? So if when we give a recommendation, any society, right, the ICM the European Bone and Joint Infection Society, you have to think about something that is available worldwide or can be available in a short period of time. 16S is not. And so this is my answer. The expert is Jamie, but this I think this is the reason. I don't know, Jamie, you have
I
the
think
same.
that 16S PCR was the first PCR to be used in that was used for the diagnosis of prosthetic joint infection many years ago. It has some advantages. It also has some disadvantages. It is a homemade PCR, which means that you need a specialized laboratory, molecular biology lab, with specialized technicians and specialized facilities, which means that most hospitals cannot perform 16S because they don't have such facilities. But it is not a problem. There is also a problem of reproducibility, which means this is a problem for all homemade PCRs because the same protocol doesn't work equally two different labs in many cases. And this is a problem for 16S. You have also the problem of polymicrobial infections. 16S PCR cannot distinguish between monomicrobial or polymicrobial. So you can have problems in some cases with polymicrobial infections. And for next generation sequencing, the fact is in the present days, it is experimental in most cases. There are hospitals that are using next generation sequencing for diagnosis. It's okay, but we don't have criteria for for example, as breakpoints to define the number of copies that you need to establish that a microorganism is the cause of the infection or not. Because I have heard in some conference many years ago that we don't need to know all microorganisms that are present in a sample. We need to know what is the microorganisms that we need to treat in order to cure the patients. And this is very important because in the present moment we have there is a study about next generation sequencing by the Mayo Clinic team in the past that they show that up to 6 to 8% of patients without infection has positive results with next generation sequencing. But we don't know what it means because these patients was not treated. This patient evolves okay, so it is microbiome. It is normal microbiological organisms in the synovial tissue. We don't know. So we need to establish a proper criteria to perform interpretation of next generation sequencing. And we will see this in the next years, probably, because next generation sequencing will revolutionize the microbiological diagnosis in the next few years. And probably when we have this criteria and when we can overcome all the problems of next generation sequencing, which has a lot of problems, we will have extremely potent tool to perform the diagnosis. And probably we will have a specificity is higher than 95%, and with sensitivities higher than 80% or 90%. So we can have a methodology that can be used. It is not a rapid technique; it is a slow technique, but we will have a very good method for the diagnosis of infection with next generation sequencing in the future, but not in the present. So that's the reason because it has not been we cannot recommend to use next generation sequencing in these definitions in the definitions from societies because it has an impact as Francesco has said a very important impact in the law with the lawyers and so on. So it can be a problem in some cases.
Got to keep everyone happy. Some exciting things in the future, though. I wanted to take the opportunity to thank everyone for your questions and for joining us today. And we have reached the end of the Q&A portion of today's session. You will be receiving a follow-up email from us with access to the recorded archive for this event. And a final thank you as well to Dr. Esteban and Professor Indelli for a very insightful and engaging presentation. To our audience, we hope you found this webinar informative. It has been my pleasure to be your moderator. And on behalf of the team and our sponsor, Biomeria, we thank you for joining us. Until next time, please take care and bye for now.
Thank you.
Thank you very much.